theme that resonates through a lot of changes in breast cancer surgery, and that is that bigger is not always better. And I'm going to start by focusing on some of the historical changes that we've seen in breast cancer surgery, and then use this to focus on two more recent controversies that have really been in the news in the research field. So starting out, just looking at treatment in the breast. Historically, breast cancer was really a surgical disease, and the thought was that any organ that had tumor in it should be surgically removed, but also any tissue around it, anywhere that cancer could locally spread, should be removed with a large operation. And what we've learned over the years is that it really has to do with the knowledge of the biology of breast cancer, and in addition, the amazing advancements in systemic therapy, meaning chemotherapy, endocrine therapy, targeted medications, as well as radiation therapy that you guys will hear about shortly, that have really improved local control in addition to surgery. And that has allowed surgeons to perform less aggressive, less invasive procedures that have fewer side effects and can really focus more on cosmetic outcomes and as well as to cancer outcomes. And so breast cancer treatment has really morphed from a radical surgery treatment to really true multimodality therapy. So looking at some pictures, if we just talk historically, breast cancer was initially treated really with a radical mastectomy. And in the picture you can see this was an operation that removed not only the breast tissue and the overlying skin on the chest wall, but really the majority of the lymph nodes in the area. And we always think of the lymph nodes in the axilla or the nodes underneath the arm, but oftentimes the surgery removed lymph nodes from the internal mammary train along the sternum.
It's hard to hear you.
Yeah, maybe it's
hard to hear.
Yeah, that's
much better.
Sorry, I'm tall. That's why I asked. Thank you. Is that better?
Much.
Okay.
Thank you.
So in this operation, as I was saying, the lymph nodes, not only in the axilla, were often removed, but oftentimes the internal mammary nodes along the sternum, and even sometimes a more radical procedure of taking the nodes up onto the neck were removed, in addition to the pectoralis muscles of the chest. And so you can see on the picture on the right that really left a significant cosmetic deformity. It's a major operation, a long recovery, and significant morbidity from all the lymph node dissection and arm morbidity, So some of the early breast cancer studies really looked at specific surgical questions and showed that it was safe to do a less aggressive surgery. And so here is a picture of what we remove in a modified radical mastectomy, meaning not removing the muscles on the chest, and also minimizing the lymph nodes that were removed. And so again, you can already see a difference here in terms of a cosmetic outcome, but we also importantly know that this was a safe cancer operation. And so moving along this spectrum from a radical mastectomy, modified radical mastectomy, what we most commonly perform now if we're doing a mastectomy is what we call a skin-sparing mastectomy. Again, with the goal of removing all of the breast tissue, but here we're removing really just the nipple areolar complex and a small ellipse of skin so that we can really leave that envelope of skin over the chest wall, which allows us to do immediate reconstruction. And so that's a huge benefit for patients. It's quicker recovery, it starts the reconstruction right away, and we know from studies that it's safe to leave that extra skin, that there's no increased risk of recurrence when we do skin-sparing mastectomy compared to the older types of surgery. And so as we continue to progress, doing less invasive surgery, really concentrating, as long as it's a safe cancer surgery, on better cosmetic outcomes, breast cancer surgery really changed in the 1990s when we realized that breast conservation was equivalent to mastectomy when we talk about survival outcomes. And so here we're talking about doing a lumpectomy with whole breast radiation. And I'm sure that we'll hear a lot more about different types of radiation and possibilities there. But from a surgical standpoint, what we're looking for candidates for lumpectomy are women who have cancer in one part of the breast. And this is a little bit of a subjective thing, but when the breast to tumor size ratio is what we consider appropriate for a cosmetically acceptable breast. And that's really based on the amount of tissue that we think needs to be removed at the time of surgery compared to the size of someone's breast. And lastly, that there are no contraindications for radiation therapy. And so, again, long-term follow-up from a number of studies showing that women who were treated with either lumpectomy or mastectomy really had the same survival. And in the clinic, I find that people are really accepting of that statement, but what I have trouble with, and I hear a lot of, I think, misinformation from women, is that they're very concerned about the risk of local recurrence between the two surgical options. So what I've listed here, this is just a review looking at some of the factors that we know are related to local recurrence after breast cancer surgery. And so some of these things we have no control over. We know that women who are younger have slightly higher risks of recurrence, as well as different types of breast cancer biology. And so we'll talk a little bit about the subtypes of cancer as indicated by receptors. So we always talk about estrogen and progesterone hormone receptors, as well as HER2. And this is a busy slide, but I just want to highlight a couple of the numbers in these boxes. So this is looking at the rates of local recurrence, meaning cancer coming back in the breast after lumpectomy and radiation at 5 years. And in the red box on the left, what's labeled luminal A or luminal B cancers, those are really estrogen receptor positive, HER2 negative breast cancers. So the most common type of breast cancer that we see. And what you can see from these numbers, while it ranges from 0 to 5%, the vast majority of these studies show that after lumpectomy with radiation for this type of breast cancer, the risk of recurrence is about 1 to 2%, which is a very low number and very similar to what you would expect after having mastectomy. In the box on the right are triple negative cancers, meaning negative for estrogen, progesterone receptor, and also HER2. And we've traditionally thought of triple negative cancers as being more aggressive breast cancers. And you can see that the rate of local recurrence is higher than the luminal cancers that we just spoke about, with the range, again, a very broad range, 0 to 17%. But the majority of these studies show a rate of about 5 to 10% risk of cancer coming back in the breast at 5 years after this kind of treatment. What's really important to take from this, though, is that that doesn't mean that bigger surgery trumps biology. And so studies have looked specifically at whether or not women with triple negative cancer do better if they have a mastectomy or if they have wider margins. And the answer to that is no. Unfortunately, the biology is really the important factor here. So more recently, 3 studies specifically looked at just this type of breast cancer, regardless of the treatment, mastectomy or lumpectomy with radiation, and the risk of recurrence was identical. And so I think that that's just a really important point to highlight here, because in the United States right now, there's a trend of increasing rates of mastectomy among women who are candidates for lumpectomy. And in studies looking to see what the reason for that is, a big reason that women are choosing mastectomy is anxiety and fear of recurrence. And so I think it's just important to make that decision with appropriate evidence-based medicine, knowing what the facts are. And the article that I've listed here at the bottom is just a recent study out of JAMA Surgery, again showing that with our current therapies, the chemotherapy that we use today, the radiation techniques that we use, that breast-conserving therapy is a safe option even for the higher risk triple-negative cancers. So while we're on the topic of lumpectomy, I'm now going to shift and talk about why bigger is not always better in the margins. So when I talk about margins, what I mean is that when we do a lumpectomy, we always look at the edges of the specimen around it. And I'll see if I can work here. So the pathologist gets the tissue and looks under the microscope at the edge of the tissue to see whether or not there are any cancer cells at or close to the margin. And universally, people have been in agreement that a positive margin, meaning cancer cells right at the edge, is inadequate from a surgical perspective. That if cancer cells are right at the edge, additional surgery is warranted, whether that be re-excision or mastectomy. But what there has been almost no agreement on is what the actual distance of a negative margin should be. So the actual measurement of tumor cells to the edge of the lumpectomy specimen. And it's probably the most contentious topic at surgical meetings, of significant variation in people's personal preference, whether that's less than 1 millimeter up to a centimeter. And the implication of this is substantial, and that across the board, about 25% of women who have a lumpectomy undergo a re-excision. Now this is a really wide number if you look at different studies, and the reason is that people use different recommendations for who needs additional surgery. And interestingly, about half of women in these studies had a re-excision to quote-unquote obtain wider negative margins, meaning they already had negative margins and the surgeon felt that additional tissue would be beneficial. And there are a lot of consequences to this if it's not helpful, if it's not impacting our outcome. And that is that we know that you can have a worse cosmetic outcome if you have to go back for a second operation or have additional tissue removed. There's potential in delaying additional treatment if someone needs chemotherapy or radiation after surgery. Requiring another surgery can postpone that. And importantly, we know that there's increased healthcare cost, and that's a really hot topic in terms of finding different areas within all of our specialties where we can really minimize excess healthcare costs. and also an increased potential risk of infection and exposure to anesthesia. So to try and come up with a consensus for universal recommendations for who requires additional surgery based on margins, a consensus group was formed, and basically this included representatives from the breast cancer surgery world, medical oncology, radiation oncology, pathology, and just a couple months ago they reported their consensus, their outcomes, in a number of different journals. And basically they met and reviewed all of the updated literature on margin status and the risk of recurrence based on different distances. And what they found and agreed upon was that positive margins, like I said, are inadequate and require additional procedures, but that a negative margin should really be defined as what they call no ink on tumor, meaning no cancer cells right at the edge. And that any additional distance, whether it's an arbitrary number of 1 or 2 millimeters compared to 5 millimeters, isn't associated with a substantial reduction in the risk of recurrence. And this has a lot of implications for all those things I just mentioned in terms of the cost and the need for additional surgery. And so then moving on to another area that we operate on, and lastly, bigger is not always better in the axilla. So we all know that lymph node status is a really important piece of information when we talk about breast cancer from a prognostic standpoint and also in terms of determining the appropriate treatment and outcomes after breast cancer therapy. And traditionally this has been done by doing a procedure called an axillary lymph node dissection. And that's a surgery that removes, we say level 1 and level 2 lymph nodes, but it's really the majority of the lymph nodes underneath the arm on the side of the cancer. And it's a very accurate way of getting this information. It allows us to look at all the lymph nodes and know whether or not there are any cancer cells there. But the problem is that this surgery is really associated with significant side effects. And most feared is what I've shown here in the picture, which is lymphedema. And lymphedema is swelling of an extremity. And the reason that this happens is that the lymphatic channels in the body help drain fluid. And after the lymph nodes have been either disrupted or removed, the body has a harder time removing that extra fluid. And after this procedure, the risk in someone's lifetime of getting lymphedema is 20 to 30%, which is really substantial. And while we have some treatments to help minimize the effects of this, it's unfortunately irreversible, and we don't have a cure for lymphedema right now. Some of the other side effects from the surgery are sensory changes because the nerves that supply sensation to the arm are right next to these lymph nodes, and they can get irritated and cause numbness and funny sensations, tingling. And there's also a longer recovery and potential arm morbidity from the procedure. So anything that we can do to minimize these, again, as long as we know that it's a safe cancer operation, was really welcome. And so in the past about 15 years, sentinel lymph node biopsy has really revolutionized how we stage the axilla for women with breast cancer. This is a procedure that allows us to remove just a couple lymph nodes to get that same answer. And what we know now is that in the lymph nodes underneath the arm, there are a couple sentinel nodes, and they're really gatekeeper lymph nodes, that if cancer cells had traveled from the breast tumor to the lymph nodes, they would go to these sentinel nodes first. So at the operating room, we find the sentinel nodes, remove them, and the pathologist then has those first couple of lymph nodes to look at under the microscope and see if there are any cancer cells. And from a surgical standpoint, this is a much quicker operation, smaller incision, faster recovery, and importantly, the rate of lymphedema after this operation is about 2 to 3%, which is substantially lower than the numbers we talked about from an axillary lymph node dissection. So this procedure really became standard of care for staging, answering the question, are the lymph nodes positive or negative? And then what happened next was that if your sentinel lymph node was negative, no additional surgery was performed. If the sentinel lymph node was positive, a woman then went on to have a complete axillary lymph node dissection. So once this became standard in practice, some questions started to arise. And the first question that came up was, what happens if someone has a really small focus of cancer in the lymph node? Do they still need to have that full surgery to remove the rest of the lymph nodes? Does that matter? And so here I've listed what we call micrometastatic disease. And this means that there are either just a few cells within the lymph node or an area that's less than 2 millimeters under the microscope. So what we would consider really low volume lymph node disease. And the initial studies looking at this showed that regardless of if you just had a sentinel lymph node biopsy or a complete axillary lymph node dissection, there was no difference in your outcome. And so you could be spared the side effects of that additional surgery. So we have the information from the sentinel lymph node, but no need to go on to have a bigger operation in that situation. So following that, the next question is, well, 2 millimeters seems like an arbitrary cutoff for that. So what about somebody who has cancer in the lymph node that's bigger than 2 millimeters? And the study that I've put up here, ACOSOGZ11, really has changed practice for women with positive lymph nodes. So this was a trial that looked at women, a very specific group of women. So this is important to keep in mind who this applies to. But these are women who had tumors in the breast that were less than 5 centimeters. They were all treated with lumpectomy and radiation to the breast, and they all underwent sentinel lymph node biopsy. In the study, for women who had 1 or 2 positive nodes, they got randomized. So half of those women had standard of care axillary lymph node dissection, and half of those women didn't. They had no additional surgery on their lymph nodes. And the women were followed, and after about 6.5 years, there was no difference between the groups. So no difference in survival outcomes, but also importantly, no difference in risk of regional or local recurrence. Regional recurrence meaning the chance of cancer coming back in the lymph node. Because that's the fear, if we're leaving some cancer behind, is that going to put you at higher risk for having cancer come back in the lymph nodes farther on. And the rate of regional recurrence at this time was less than 1% in both groups, which is exceedingly low, and really shows that the additional treatments that we're using are really impacting and lowering local recurrence. And so like I said, this has changed standard of care for women who meet these criteria. So right now, for patients who are having lumpectomy and radiation, who have the tumor size that I talked about, if you have 1 or 2 positive nodes, we know it's safe to not go on and do that completion axillary lymph node dissection. And after this was published at Sloan Kettering, the surgeons took this into practice, and everyone uniformly applied these criteria to patients. And what we found, and just published a little while ago, is that out of all women, again, who meet these specific criteria, had lumpectomy and radiation, with 1 or 2 positive nodes, 85% of women didn't end up needing an axillary lymph node dissection, which is an amazing number of the number of women that we can prevent the exposure to the possible side effects of an axillary lymph node dissection. So this is just not important to look at all the details, but just showing an algorithm of how we decide what the right lymph node surgery is for different women. And what it really boils down to is that the surgery that we now do on the lymph node has a lot to do with what surgery you have on your breast. So, whoops. So here I have breast conservation. So if a woman's having a lumpectomy and radiation and has a negative sentinel node or 1 to 2 positive nodes, no further axillary surgery happens. It's only if there are 3 or more positive lymph nodes that we go on to do the axillary lymph node dissection. And this is different than women having a mastectomy. If a woman has a mastectomy and a positive sentinel lymph node, she then goes on to have an axillary lymph node dissection. And the reason is that we don't have the study that answers that question. So the research that we used to answer that question came from women having a lumpectomy with whole breast radiation. And so this leaves us with a lot of questions. Number 1, does the same principle apply to women treated with a mastectomy? And right now, we don't have good data to say that we can safely omit that operation. Number 2, is radiation an appropriate alternative to axillary lymph node dissection for higher risk cancers? And lastly, which is a big area of ongoing research right now, is it safe to omit an axillary lymph node dissection for women who have neoadjuvant chemotherapy, meaning chemotherapy before their surgery, if their lymph nodes respond to the treatment? And so these are a lot of things that we're actively pursuing that hopefully in the next few years we'll have better answers to. And I'm sure some of these topics will probably come up in the next discussions when we talk about radiation. So that is all I have. Thank you for your time, and I know